Okay, so good evening, everyone, and thank you very much for joining BOMSS tonight for our educational webinar. We've got an absolute superstar guest speaker in Jamie Kelly, who I will introduce properly shortly. But in keeping with tradition, just to give you heads up notice on the next couple of events, on the 14th of July will be Journal Club, which will be hosted by the Sunderland Bariatric MDT. Looking forward to that. And we did have a session scheduled on the 28th of July. Stephanie Sogg from the USA was going to give us a fantastic talk. I've had to reschedule that, and I'll keep you updated with the new date in view of the BOMSS ASM, the annual Congress, moving dates to that particular week at the end of July in view of COVID restrictions. So we'll come back to you on that later. But in the meantime, my pleasure really to introduce Jamie. So Jamie Kelly is an upper GI and bariatric surgeon in Southampton, and he is I'm not speaking highly enough, but he is the UK expert on endobariatrics. And I've asked Jamie and invited him on behalf of BOMSS Council to come and talk to us about the endo sleeve, to share his vast experience of over 250 procedures, and in terms of the learning curve and the tips and tricks, and hopefully you'll all enjoy the educational webinar tonight. Thank you to Gore for supporting tonight's session. And as always, the session is recorded and will be made available to BOMSS members. And please, can I ask you to post your questions via the Q&A function at the bottom of the screen. So without further ado, Jamie, welcome and thank you very much, and looking forward to your talk, and we'll have the Q&A for about 10 minutes or so at the end.
Thank you very much, and thank you very much for inviting me. I'm very grateful to be able to present some of the work I've done and others have done, and to try and explain ESG in a little bit more detail. I thought I had a little bit longer than I do, so I'm going to flick through some of the earlier slides. But essentially, what we're trying to achieve. Is that all right, Sharif? Am I working, or is it a problem?
Yeah, you're working fine. We can see.
Sorry, there were messages coming up there. As we know, less than 2% of those who qualify for bariatric surgery will actually undergo an operation, and that's part of the associated fear of the risks, the morbidity of the surgery, often the cost, and that then follows on the accessibility, and unfortunately patient preference, and the significant stigmatism that the population have around the surgery. So often when I'm sitting in my bariatric clinic, I've got a 67-year-old in front of me with loads of end organ injury, and I'm trying to manage their expectations to explain that surgery is no longer viable. I often drift into working out, I wish we could get to these patients earlier and stop all of this happening. And that was one of the driving factors for me and endobariatric surgery. I will sort of flick through this very quickly, but this is just a sort of a prelude as to where we've got to. So in 2010, we started in Southampton, myself and Jim Byrne, endobariatric procedures. First, we started with the pose. Essentially, it was proof of concept. I'm happy to go into a bit more detail at the end, but I'm going to flick through those slides. A lot of it was just incidentally, the good results that came out of Barcelona, we felt were probably mainly due to an intense follow-up regime and Catholic guilt. But the pivotal trial there from the States showed that we were right and there was early weight regain. So yeah, we then moved on to the endo barrier after that. And again, that was an improvement, and we were beginning to treat the metabolic complications of obesity. But again, the pivotal trial from the States demonstrated that the complication rate was too high. We saw that as well. We saw significant complications, and that essentially left it dead in the water. But it was a bit of an advance, and it was a longer duration, and we were starting to treat the illness a bit better. So that led us into the Apollo overstitch. And really, although it was first reported in 2009, it was the first sort of use was 2013 by the Mayo Clinic and Harvard, reducing stomal output of gastric bypass surgery. I'll flick over the results of that, but I want to stress one thing. This is a piece of work that is really undervalued, and it's done by Christine Stier from Germany. And essentially it is treating type 2 dumping in gastric bypass patients. Now, as you know, type 2 dumping, they have their meal, they get the insulin overproduction, and they become severely hypoglycemic at about 2 hours or so after the operation, after the meal, and they can end up collapsing. They get drop attacks, they lose their driving license, they lose their job, they can't look after their kids. The stomal reduction stops that pretty much instantly. You don't have to go through the acarbos, the dietary changes. If you can get your endocrinologist to prove it, look at the result. They are amazing, and Christina's done many more now. And the SIGSAD score goes from 18 pre-op, and a week later it's down to 2. They get their license back, they get their life back, they get their job back, etc. It's a bit of work that's often forgotten about. Please remember it if you're having trouble with those patients. Right, ESG. First reported again by the Mayo Clinic in 2013. I think I did the first one right at the end of 2015 or beginning of 2016. And worldwide, there's now over 30,000 cases have been performed. This is a useful sort of, what I'm going to do is I'm going to take you through the how we do it. Then I'm going to take you to how it works. And then I'm going to take you through some of the literature and then move on to the controversies around the procedure. And then we'll take it from there. This is a sort of a company supplied animation, but it's quite useful to describe. So first, the patient's under general anesthetic. I go down, have a look into the stomach, make sure there's no big hiatus hernia, no ulcers, give it a good washout, and make sure I've got good vision throughout. Okay, this is an old thing. This was when we used to mark the stomach with argon ablation. None of us really do this anymore. The argon with the blood and the fluid just disappears, the lines disappear. Then we put an overtube down the esophagus to protect the esophagus so we don't hold that, putting the device in and out. And then we start doing the suture patterns. I will come back to suture patterns later in the talk. The importance is to get a full thickness bite. That is absolutely critical. And then the suture patterns are essentially narrowing and reducing the volume and shortening the stomach. Okay. We tend to leave, this is another one, we tend to leave the top of the fundus open to create a little pouch. Some people put additional sutures in to support it. Okay. 1 second. So I tend to perform my cases on the left lateral. Some people prefer supine. It's really your own preference and what you're happy with. I find I get a bit more access and maneuverability of the scope on the left lateral, and it's predominantly while I do it. You have to be a bit careful because there are 2 cases worldwide, one at Harvard and one in Madrid, where the gallbladder has been stitched into the stomach because the patient has been too far over and you have to have the patient slightly leaning back to minimize that risk. This is myself and Gontran Lopez Lava. I think I can't remember if this is a training or where we're at here, but this is to give you a demonstration. It's not as easy as it might look on a cartoon, essentially. The Helix device is in the stomach there. We've loaded the needle into the delivery system. We're now positioning, so we're getting we're able to get a full thickness bite. We then pull it, we've pushed the needle through, we're pulling the needle back off, and then we're releasing the device, and you'll see that now coming off. And the stitch is through the full thickness, and the helix is also, as you can see there, is full thickness. And then we're pulling a bit of stitch through. It is a bit bleedy and it gets a bit fiddly. And now we're just loading the needle again to do the next stitch. And again, you've got to have patience, okay? We're just putting the helix device in to get for the next stitch, driving that in, and then we're repeating. And what I want to demonstrate here is if I push this out to about 6.5 minutes, we have put 5 bites in, and this is Gontran. He's just snugging the stitch down, and it's coming together. But that has taken us 6.5 minutes, and it'll be 7 minutes by the end. So that is just one stitch with 5 bites. It takes time. It is fiddly. You have to have patience. Okay. This is, I think, one of mine from the end result, taken in about 2017. And I'm pulling the scope back whilst insufflating to give you an idea. So the antrum is spared. Coming back, you'll see there's the first stitch there. And then as we're coming back, I'm insufflating, and the stomach, the lesser curve is on the right, and the plication is on the left. Nice, relatively narrow. You can see the plications nicely there. And then off to the left at the top here is a little gastric pouch. Okay, not particularly visible there, but the next slide, which is a radiological slide, it gives you a good indication of what it looks like. So what we've got the esophagus coming down into the little pouch. You can see the tags there from the stitches. There'll be more tags out here which are missed, but you've got a nice reduction in volume. We've not taken any of the stomach away. It's completely innervated, and you've got a little pouch. Okay, now that is really important, as the mechanism of action is so important, because it is different than anything else that we do. There's some computational mechanical modeling that's recently been done, and it's quite helpful because it sort of reinforces. Just remember, the L's are the sleeves and the E's are the ESGs. So what we've got here is the sleeves here, and we've got a significant reduction in volume. We've got a good reduction in volume, again, with the ESG, but it's not quite as much, and we're not intending it to be so. And also the stiffness is significantly high with the sleeve, but it's not so high with the ESG. And that is important, because what we've got here is it's not a restrictive procedure. I cannot emphasize that enough. We hate it being called a sleeve. It misleads people into thinking that that's how it works. What it does is the food comes down into that pouch, the stretch receptors get fired off, and they feel fullness, satiety, and they use that to portion control. All right, and there's also some delayed gastric emptying. So it is a sensation that they use to portion control. It is categorically not a restrictive procedure, and if patients use it as such, they will bust it. The guys at the Mayo did a lovely study demonstrating how this works. The bottom bit here demonstrates that the satiety in a normal patient, that was where the median figure was, 960 kilocalories, but after a sleeve, not only was the time was reduced to get to the satiety, but it also reduced the calorific intake down to 1/3 of what they did beforehand. And there's this other beautiful bit of scintigraphy demonstrating how in a normal patient, 180 minutes after the meal, most of the meal is down in the small bowel, whereas in the ESG, 180 minutes later, most of the meal is still sitting in the stomach. If we look at the hormonal changes, well, unsurprisingly, because we're not taking anything away, there isn't a great deal of change in the gut hormones. There is a slightly odd thing that several studies have now picked up is there's a weight-independent improvement in insulin resistance, which lasts for around, well, over 2 years, as far as we know. We don't quite understand that, but I think that's under further investigation. So let's move on to some of the trial data. This was the first really big trial to come out, and it was a mixture of Madrid, Cornell in New York, and the Mayo in Rochester. And what it demonstrated was that it was a repeatable procedure no matter what institution, and that there was significant weight loss, and that it seemed to be nicely sustained out to 18 months. And they were seeing a 20% excess weight loss at 18 months. We then started to see some comparative trials coming through. This one is a nice one from Barcelona, comparing the ESG with the sleeve and with the laparoscopic plication. What it was sort of highlighting was the reduced hospital stay, and it indicated the reduced risk of adverse events. In terms of results, it's exactly kind of what you'd expect. It's not as good as a sleeve, but actually it was really pretty similar to the plication at 2 years. It's another nice comparative study out of the States, and this time comparing the gastric band with the ESG with the formal sleeve. Noted the BMIs are slightly higher in the ESG and the sleeve group. But again, the results similar. It's the ESG seems better at 12 months than the gastric band, but not as good as the sleeve. Length of stay massively reduced and significantly reduced adverse events. As some of us have worked out in the States, I will caution about the length of stay. When I was out in the Mayo, I started my ward round at 5 o'clock in the morning in the hotel, but they were all still considered as day cases. So just a word of caution with the States data there. And then from the Arab nations, we had this very big study that came out 2018. I'm slightly disappointed with the study. Yes, it's 1,000 patients, but I think the study was compromised to get that headline. What we can see, if we look into the data a bit, there's too many patients really at the very early stage having had their ESG, and there's very few, well, in comparison, there's not that many out at 12 and 18 months. But it was an indication that a lot of procedures are being done, and it also again supported the relatively small number of serious adverse events. And it did again confirm there was significant weight loss, although there was beginning to see a little bit of weight regain at that 18 months in that series there. And then we've seen over the last couple of years, we've seen some systematic reviews and some meta-analyses come out. And this one was from Chris Thompson in Harvard, and nice demonstrating that, again, we are seeing nice expected weight loss and sustained out to 24 months. And again, we're seeing a very low risk of complication. If you look at these complications, you know, pneumoperitoneum is something that we do for our surgery, and some of these, a little bit of fever, we'd expect that with atelectasis after an operation. The important thing is that there's been no mortality after these surgeries. If we look at that and dig a little in more detail, if you look at the complications and classify them into Clive and Dindo, sort of 2 or above, it's about 1.5%. If you go for 3B and above, it goes down to 0.1%. And those are the gallbladder perforations, the gastric perforations, one of which was recognized at the time, and oversutured, one of which presented later and had to have surgery. The esophageal perforation was when the device wasn't closed. It was, I think it was actually at a meeting, it was being presented. And so the device was open and it was pulled back through the esophagus and tore the esophagus. That was stitched at the time, and the patient came to no further harm. The perigastric collections all have been managed with percutaneous drainage. If we look at one of the problems with the sleeve, as we know, is gastroesophageal reflux. That has now been looked at. This group from Strasbourg published this year, and they looked at the endoscopic evidence of esophagitis and biopsies, and it's completely the opposite to the sleeve. We're seeing that esophagitis decreases. We're not disrupting any innervation, and you know, the fundus and the mechanisms that control reflux are unaffected by the ESG, and so can still function. So the esophagitis actually fell from 14% down to 1.2%. Interestingly, chronic gastritis also decreased. We don't, the whole stomach is there, we don't see B12 deficiency. Long term, there is a paucity of data, and that is a problem. And I think there'll be more data coming out in the next few years, but I recognize that as an issue. However, again, this was published as an abstract, I think 2 years ago, but has formally come out now in a paper, and it's the Cornell group, and they have published their 5-year outcome data. And it is strongly suggesting that there's longevity to the procedure, that there's 203 patients starting out, and the follow-up drops to 68 patients at the 5-year mark. So not a completely representative data sample, but there is some longevity to the procedure, but obviously we need a bit more work there. So if you look at the trial conclusions to date, it is an incisionless procedure, it's reproducible, it's low risk, and there is a sustained weight loss. How much, we're not entirely sure. And it also, importantly, doesn't prevent other surgical procedures being performed in the future. Issues or debates, or however you want to put it. I mentioned the paucity of randomized trials. I'll come to that next, but there is also procedural technique around suturing and training, and there are patient characteristics. Are there people that we can pick up and not operate on who shouldn't have it, and how can we help those patients? And do we add in adjuvant therapies? Well, in terms of answering them, there are some randomized trials out there, but the biggest one is due to report at IFSO, the MERIT trial from the States. And actually, they've made a pre-announcement in the last few weeks to say that it has achieved its primary endpoints in both efficacy and safety. It's safe to say that we can probably assume, given that the same people doing the trial are the same people on the task force, the ASGE task force on endoscopic bariatric therapy, their statement was that there should be less than 5% adverse events, and the weight loss should be greater than 25% at 1 to 2 years, I think. So I suspect that's what the outcomes are going to look like, but how good they are, we don't know, and we're not allowed to know yet. But the randomized trials are being addressed, and they will start to come out. Sutures. A lot of the sort of conclusions from the trials are don't cut corners, and I would agree. Procedural time generally works out as about 80 minutes. I can't get it down less than this. but I, on average, will use around 7 sutures. If you cut the number of sutures you use, the time goes down. Yeah, so don't cut corners with the sutures. You know, you need to put them, they have to be full thickness. You have to spend time getting the full thickness bite, and you can cheat a procedure, but it will bite you in the end. This is a chap of mine who had an ESG, went to Thailand 4 weeks later, got severe DNV and ended up in hospital in Thailand for 2 weeks on a drip while he recovered. Unfortunately, and quite understandably, he sort of shredded the procedure. And that was the first indication to me that we may have to follow these patients up endoscopically. And the one group has done this really nicely. Again, it's the Strasbourg group. And what they've done is they've classified, this is their ESG. I would point out that it's quite wide in comparison to how I do it. And generally it looks like their number of sutures is about 4. And that would fit with their procedural time, which is relatively low. What they then did was they looked at the ESGs at 6 months and 12 months endoscopically, and they classified as intact, partially intact, and disrupted. Okay, so what we see is 87 patients, and at 6 month mark, we see about 7% complete disruption, about 44% partial disruption, and about 50% remaining intact. We then move to the 12 months, and they've lost half the patients, but the complete disruption rate has increased, as has the partial disruption rate, and the intact rate is less. I would also point out that the expected weight loss for an intact ESG is slightly less than we would expect in that group. Let's have a little bit more of a dig into this trial. It's really well done and it's really well reported, and they've been very honest. They comment that their suture number is 3 to 8. I suspect the median is 4 to 5. So low number of sutures. The follow-up, we don't know how much psychiatric dietetic input is put into the patients, but they are very open about their learning curve. And this is a really important bit from this paper. They comment that there is a higher rate of disruption in the first 20 cases rather than the second, rather than the third. So they are suggesting that the learning curve is not perhaps 10 cases, but it's higher. And they've even suggested that it's 20 to 40 cases in terms of the learning curve. They also freely comment that, you know, less than 50% of the patients got an endoscope at the 12 months, so they don't have the full complement of patients. There are other interesting things coming out which may actually inform our practice from this paper. In the partially intact patients, the sutures that are gone were the distal sutures, the ones sort of close to the antrum. The other interesting fact was that if a BMI was less than 40, they were more likely to be intact. Age had no effect on whether they were disrupted or not. And they were supporting they support the idea of resuturing in certain cohorts of patients. Gontran from Madrid has done this, and he classified the patients into weight failure, i.e. they never lost more than 10% of their total body weight loss. Their weight regain, where they started to weight regain, I think after a year, and weight plateau, where they got again to around 9 months and then plateaued. There were very few numbers in his case series, but what he demonstrated was that in the weight plateau group, they seemed to do best from the resuture. Again, no comorbidities. So it looks as though this procedure is potentially repeatable, or even, you know, just to give them a little boost to help them get down further. Expensive way to do it though. We also go, well, are we doing the right thing with the primary suture patterns? And there are enormous number of patterns out there. This is Rima Sharma's group from Cornell. They put in a series of Z sutures and then go over them with buttressing sutures. This is the Mayo. This is Manuel. And this is Graus Javier from, again, he's a different surgeon and gastroenterologist in Madrid. He does longitudinal sutures. There is a trial, came out last year, comparing suture patterns. Essentially, if we consider the U suture as this one, we consider this as a longitudinal suture, and this is the Mayo. It's not a great trial in that it's sort of overanalyzed, and they're trying to squeeze something out of nothing, I think, to a degree. Sorry to say that, but there are some inferences in the trial in that the longitudinal sutures seem to give a slightly better excess weight loss, but it doesn't correspond to total body weight loss, and also the number of bites in each suture also seems to give a slightly better excess weight loss. But the pattern's confusing. But their conclusion was that the important thing is to complete a technically correct gastric tube with full thickness bites. But this is where my but comes in. There is a recent trial out from Johns Hopkins that completely sort of says the opposite, in that they took patients without fundal suturing and with fundal suturing, and they found that without fundal suturing, it was better, their weight loss was better, and they were less stitches, and the procedural time was reduced, although that was only, I think, a year's follow-up. So it is really confusing, the pattern here. This is my take on it. I'm working in Southampton. I grew up mucking about on boats, breaking them, racing them, breaking them, rebuilding them. I sort of took the approach and asked one of my friends who's an engineer. I said, look, if we use a whole structure, would it work, the same way if we put a keel down and then put the bulkheads in? And he said yes. So from 2017, I started, well, actually a bit later than that, I started doing that. Essentially, I did a longitudinal stitch along the greater curve, and it really foreshortens the stomach. It also brings the fundus right down into your vision, makes it much easier to get into there. And it also acts as a lovely guide for your other sutures when you're putting in the U sutures. That's what it looks like when we look down on the scope. And then I go and do the U sutures, or the bulkheads, if you will. Okay, and I compared that with Gontran's technique from Madrid. And what we saw was there was a significant difference at 6 months of total body weight loss, excess weight loss, going up almost to 70% at 6 months. And total body weight loss at 6 months was 21%. And I was very, very impressed with this. But what I was more delighted about was the 2-year results. So again, what we saw better weight loss, and it was being sustained. With me doing the other technique, where I was beginning to see weight regain, but actually the total body weight loss at the 2-year mark was around 25%, and I was delighted with that. There's a lot of chat about should we think about adding GLP-1 receptor agonists in, and the Johns Hopkins group. It's a funny that what they've done is they're Brazilian patients, but it's come out of Johns Hopkins. But essentially they gave the Victoza to the patients at the 5-month mark, and it did improve the weight loss at 1 year. So there may be some fiddling to do with medication, and I expect to see that with all of our bariatric procedures in the future. I often get asked, could it be used as a bridging procedure? My friend Ricardo, who now works in Germany, has done this predominantly around the way the German funding works, is that he couldn't get funding to do it other than make it the sort of semi-emergency, and that's how he got those results. And it did induce weight loss in the super obese, and it actually enabled 2 patients to get off ventilators, and it got them home. So there is some evidence that it could be used as a bridging procedure, and there's evidence there that the total body weight loss is better for the class 3 obesity, in class 3 obesity. There is also some evidence coming through again from the Arab nations that the ESG can be used quite effectively in revising sleeves that have got a bit fat and distended. This, I won't play, it's essentially you're in a slightly reduced area, but it does appear to be very safe. And the results demonstrate there's an acceptable total body weight loss over 12 months. This is just a sort of sneak preview into the future. This trial came out in May, using the overstitch device to do a single anastomosis gastric bypass procedure. So they're doing it in pig models, and it does seem to be achievable. And when you then look at other options, such as the magnets from GI windows, you can place a magnet with an enteroscope and a colonoscope, and they are deployed via the scopes, and they join together, and then you get necrosis and you form an anastomosis. This has been done in humans. And so we're beginning to sort of see the evolution even further than where we're at. And we'll see that develop over the next few years. But ultimately what we're trying to do here is get a happy patient. Unfortunately, I can't show you the smiley face, but the smiley face increases throughout, and her scales tell us that she's getting better and better. And we're seeing some very happy, very pleased patients who've gone through a procedure with low risk, low morbidity. There's no scars, there's no stigmatism, they don't have to tell anybody, and unfortunately it's still quite costly. But in terms of longevity, as I've sort of described there, there's still work to be done, and there's more trials to be done. Thank you. I hope I'm roughly on time on that. Am I okay?
Jamie, you're good. You're good. Thank you. We've got 5 to 7 minutes of questions. We've had a few come through the chat function, but can I just, so a few take-home messages, and thank you very much for a really, really fantastic summary talk, and sharing your personal experience and views as well. So key messages for me: it's not a restrictive procedure. That's important.
Definitely.
Satiety inducing and delaying gastric emptying, and personally I hadn't appreciated that myself, actually.
That is, I cannot stress that. When you're seeing the patients in clinic, you have to stress that, because a lot of them assume that it's like a sleeve.
Yeah, so that leads me on to, what is your ideal patient for this procedure? Because all our patients have problems eating and controlling their eating, and some of them do rely on the restriction. So how are you going to get your patient to abide by stopping eating when the satiety goes?
Now there's a really good question. There's lots of different ways of categorizing that. I think from the results, the BMI less than 40 do better. BMI less than 35 do even better. So I think unless you're doing a bridging procedure, my ideal patient is a BMI less than 40. They have to be really engaged with the mechanism of action and understand it. I also think that if you look at the psychometric testing and everything, it doesn't pull out who's going to win and who's not going to win. However, the work that Rachel Batram has done in terms of that sort of matrix of gut hormones that suggests that some people don't feel satiety like others, I think if we could start using that a little bit, I think that would be very useful to sort of perhaps exclude patients who are just not going to be able to use the procedure properly.
Fantastic. Hiatus hernias. What's your take? Is there, if you had an anterior weakness or 1 to 2 centimeter hiatal hernia, does that play a role in patient selection?
No, it doesn't bother me. That doesn't bother me. I think if I start getting over 5 centimeters, it does bother me.
Yeah.
I think when I do that longitudinal suture, and it draws it down, it actually to a degree reduces the hiatal hernia. And it was interesting data, that Strasbourg data demonstrates that the hiatus hernia is not increasing in size in their 20 patients that they found one over that year period.
Would you mandate pre-op OGD in your World Cup for these patients?
Yeah, here lies the American-European debate. So yeah, in an ideal world, yes, if they have significant gastroesophageal reflux symptoms and they have never been investigated, yes. Reality is if they don't have symptoms, then no, I go down and assess at the time.
Okay, and Dev Bansey from Imperial has just posted, would you eradicate H. pylori first?
I haven't done, I think, Dav, it does, when you get a lot of gastritis, it makes the procedure slightly more difficult because you get a lot more bleeding and it's potentially more difficult to get the full thickness bites. Should we blanket treat everybody for H. pylori beforehand? Potentially, yes. I don't know of anybody who's done that yet. But it's interesting that the gastritis is actually settling by itself post-procedure.
We've had this question come from the audience during your talk, and I was going to ask you as well. Revising an endoscopic sleeve to another procedure. Any tips? I've personally revised an ESG that was done in Brazil years and years ago, and patient weight regain, and I revised her to a bypass. I was nervous to revise to a surgical sleeve because I wasn't sure about the position of the sutures. So what's your tips for us who are coming across these patients who've been abroad for these procedures?
Yeah, or you can revise mine if you like. I don't mind. No, I've revised them to sleeves and bypasses. I've done one of my own, and he put his hand up and said, look, I just didn't use the procedure, and he bust it within 6 months. He ate horrifically aggressively. And so we converted him to a sleeve. And I've done 2 others from elsewhere. I've not had a problem with doing the sleeve. When you've got the 2 tags, you've got the metal needle and you've got the plastic tag on the end. Generally, I'll look down endoscopically, just get an idea about what it's like on the inside. But it's rare that we would place the sutures in a position that would affect doing a sleeve.
Good.
So for me, I use a 36 French bougie, and I'm comfortable that I should be well enough away from the tags. If I'm not, I can just, if the stomach's fully mobile, I can just, normally you can visualize it and take it away.
Okay, very useful tips, actually. A couple of other questions from the audience. Chetan is asking, with your compression suture, is it easy if any of this patient needs a sleeve gastrectomy? Will your compression suture affect a future sleeve gastrectomy?
No.
In terms of its location?
It's right on the greater curve. It's miles away from anything you need to do.
Okay, and what about, will the ESG hide dysplasia and gastric ulcers that develop in patients with gastritis? So this is all hidden from endoscopic view in the future.
Yeah, so I mean, I think I wouldn't do this in somebody who has a family history of gastric cancer, because you want to, yeah, but that's why I put that slide up there about it seems to reduce the gastritis. And we haven't seen any sort of problems in terms of ulcers, peptic ulcers developing. We're generally staying away from the antrum. Yes, it is going to mask stuff. we haven't had any problems yet, and it's been going since 2013. And I don't know if in the meetings nobody's discussed it, nobody's found anything. It's not been reported.
What's your view on the mechanism of improved reflux? That's a surprise if it's delaying gastric emptying.
Yeah, I wonder if it's partly dietary change, partly weight loss, and actually I do wonder, because what you do see is the stomach is sort of shortened and the fundus is sort of brought down, and I wonder if that helps the sort of angle of hiss and everything, so it reduces the degree of reflux.
Okay. We had a bit of a chat about this before the webinar started, in terms of commissioning the services and so on. So, I mean, Derby as a unit, we've been thinking about endobariatrics for a long, long time now. A group of us have done the wet training with Apollo in the lab. How do we take that next step to get it established as an NHS procedure, or is that just out of the question?
I actually strongly, and I think I don't think, I know I've recently published on this. I think it has to be done in the context of a trial. There is so much paucity of proper randomized trial. The data is there, but it needs to be in the right context. And I think just trying to put this through commissioning, I would completely understand this would and potentially should get rejected. But if it's in the context of a trial, I think it should be our next step nationally.
Okay, we had a question about training, and should trainees be learning how to do this? I was going to ask you what you think your learning curve was. How many procedures before you felt, I've nailed this?
Still learning.
Very
no. Honestly, I am actually. I still tweak it a little bit here and now, and change it a little bit even now. 250 cases later. Yes, trainees are more than welcome to come and see me do them and watch them. And yes, we have lost achalasia. I do poems. I don't do any Hellas anymore. I just do poem procedures. As a surgeon, I'm sad. I love doing that. But actually the poem outcome is better. And we are, the reflux, that is going to go. There are procedures coming through there. We'll lose the reflux. That'll go endoscopic as well. And we've lost, the high-grade dysplasia, and the early cancers. We're doing ESTs, EMRs, where I'm removing those. 10 years ago, I would have taken them out. So yes, trainees have to get involved in this, because I think, there should be this discipline that sort of bridges gastroenterology and surgery. As surgeons, we're more prepared to take the risks, and because we know we can get ourselves out of jail. And we can't leave everything, sorry, Dav, to the gastroenterologists.
Well, Dav has just very helpfully pointed out that Imperial has just allowed them to start a program of ESG. So well done on getting that off the ground. Fantastic.
I'll see you in July, Dav.
So Jamie, listen, we're out of time, but we could literally go on all night asking questions. It's so interesting, and thank you ever so much for your time. Okay, and for the attendees, there'll be a recording made available of this webinar, which will also be posted out to membership in due course. So thank you all very much. Jamie?
Thank you very much for inviting me.
Pleasure, absolutely. And thanks to the sponsors and attendees, and good night. Thank you, Jamie.
Thanks.